Thank you for inviting me, and I'm very happy to be here and be part of the 10th year anniversary. So my role is to talk about fluorescent imaging in enhancing pancreatic surgery today. And green button, I have to remember this. Okay, there's nothing for me to disclose. All right, I'm going to start by this consensus statement, which was basically published by most of the experts here, as you know. And the thing with pancreatic cancer, pancreatic surgery, is that up to 40% of them presents with occult metastases, which are very difficult to diagnose preoperatively. And even up to 50% of them develop or undergo R1 resection. So this particular consensus statement has shown us several statements. And the issue here is that we can see that the use of fluorescence in pancreatic cancer has not been disseminated and has not been developed over the years. So out of the 18 experts, even those who are part of these statements, only 13 of them have performed fluorescence-guided surgery in pancreatic cancer. And most have used this for less than 5 years. So we know that development in pancreatic cancer with fluorescence is very limited. So going through all these papers, from the logistics, all the statements regarding the logistics, to clinical applications, and all the tumor-targeted probes as well, shows that why is it necessary and where is it needed for pancreatic cancer surgery. These are the reasons why we are very concerned with. It's because of the presence of metastasis. I mentioned earlier the occult metastasis, the tumor location, especially for small tumors and in pancreatic neuroendocrine tumors, lymph node metastasis, margins, viability of vital organs such as the pancreatic stump, the hepatic duct, and the small bowels as well for the anastomosis to create the better quality of the anastomosis. And all of these have to do with these particular issues, such as liver metastasis, tumor identification, where the boundaries of the resection will be better identified, and adequate lymph node harvest that would impact the prognosis, and achieving R0 resection, and of course perfusion assessment for the pancreatic stump, and also for the bile duct and the bowels as well, so that we can mitigate complications. So this paper is a very recent publication that shows a review of 23 studies concerning 720 patients, where all these 5 topics were addressed: perfusion, tumor detection, lymphography, cholangiography, and targeted probes. I'll go through them, each topic one by one. So firstly, you will see that most of these studies are consisting of small numbers of patients in single centers. And so most of these have very initial studies and still in the development stage. And you will also note that they have different endpoints, different outcomes, different dosaging patterns and administration as well, and also different equipments. So there's a whole lot of variety in terms of the use of fluorescence here. Now we talk about tumor detection. These are the following studies that have shown the use of tumor detection, and only one has shown its use for neuroendocrine tumor, which I will elaborate later. So in our experience, what we do routinely is to use it for tumor detection or for detection of liver metastasis, occult metastasis, especially those that are less than 5 millimeters, very small, that were not detected by the CT. And so this is a patient that has presented with no liver metastasis, localized pancreatic cancer, but on diagnostic lab, we see all these tiny tumors on the liver, which has changed our strategy and our decision to perform pancreatic duodenectomy in these patients. So this is one important application, and together with intraoperative ultrasound, we're able to detect smaller lesions even intraoperatively. And when we sent for frozen section, the biopsies turned out to be positive for metastasis. So this made us abort our surgery. For adenocarcinoma, most of the studies have shown that this doesn't identify the tumor, and detection rate was indeed very varied. While for neuroendocrine tumor, the group of the late Claudio Bassi, may you rest in peace, have shown that after 5 milligrams of injection, IV injection for 5 times with the interval of one minute per injection, most of them, 90% of these lesions will be detected after the second injection. And the average latency was 80 seconds with an average visible time at 220 seconds. And these have shown that most of them have been non-functional lesions apart from 2 insulinomas. So this is an example of how we applied this also in insulinoma. 7.5 milligrams was injected, and you will see that the lesion now perfused with the fluorescence. It has also helped us in deciding intraoperatively in this particular 4 patients where we are able to perform HPD, hepatopancreatic duodenectomy, and one of them parenchymal sparing hepatectomy. 2 of them were biliary tumors. One is a papillary, and the other one is a mucinous adenocarcinoma. And 3 of them were neuroendocrine tumors. So all of these patients underwent R0 resection, completing the liver and the Whipples at the same time, with the 5 years overall survival of all of these patients are still surviving as of now. So this is a good application where we see that the lesions are located only in one lobe, where we are able to do right hepatectomy in all these patients. And the other one, posterior sectionectomy. So the next topic is on lymph node metastasis, and we know that preoperative detection sensitivity is only up to 38% by PET-CT, so it's very difficult to detect preoperative lymph node mets. So Hirono et al. Used this in 10 patients in 20 patients with an intratumoral or peritumoral injection anteriorly and posteriorly with 1 milligram. And they were able to show this different lymphatic drainage. And these are very important because we know now where the lymphatic metastases occur. And this we do in taking all of these lymph nodes and block, which is crucial because the number of lymph nodes in pancreatic cancer impacts survival. So it was also known that this lymphatic pathway reaching the left side of the SMA was observed in 4 patients, while that reaching the para-aortic region was in 17 patients. And the time to reach this SMA was longer than those that reached the para-aortic region. So now we come to the perfusion studies. In the perfusion studies, most of the studies are talking about vascular identification to mitigate ischemic gastropathy, especially in DP-CAR, and also to improve the quality of anastomosis to prevent postoperative pancreatic fistula and postoperative pancreatitis as well, which is becoming more recognized these days. And in these patients, there were varieties from 2 milligram to 7.5 milligrams intravenous injection. So this is another example of where we apply this is for splenic preservation, where ICG is injected to show us the SMV, the splenic vein, the splenic artery, especially when we have our fellows and our residents doing the case. So it can be easily identified by our fellows, our trainees. So we would routinely inject 2.5 milligrams per milliliter of ICG, and only 2 milliliters, 2 ml is needed to show that the vascular structures. So here you can see the SMV and SMA, the splenic vein and splenic artery clearly identified, which is appreciated immediately about 15 to 45 seconds after injection, while the venous fluorescence comes a bit later, about 10 minutes later. So here also is another example where the arterial the GDA and the hepatic artery are fluoresced, but you can see the pancreas also. There's some form of enhancement or perfusion on the pancreatic stump, but not completely. This is what we call as hypoperfusion or heterogeneous perfusion. So I'll show you here what it looks like and the timing. As you see here, when at 2 seconds after injection, the celiac artery immediately shows, and then at 6 seconds, common hepatic artery, the GDA stump, the SMA, and at 9 seconds, you can see clearly the IVC and the renal vein nicely perfused. And there's a transition at around 12 to 18 seconds where there will be perfusion of the pancreatic stump, and the rest of the bowels begin to show the green. And so at 30 seconds, you see more and more, and now the SMV begins to fluoresce up to 50, 60 seconds, or even more. So this is what we see with the use of 3 ml of IV given during this pancreatic surgery. And this is the example of how it looks like. If it's a heterogeneous perfusion above and the one below, it's a better homogeneous perfusion. And it's a hit or miss. We don't really see this very consistently. There are times when we only see some heterogeneous perfusion. And with this, we also noted that this is care of our friend Diresh from Nepal. They did 40 cases, and they showed that in this 11.6%, these 5 patients had hypoperfusion of the pancreatic stump, and eventually developed post-operative acute pancreatitis, where 5 of them have high hyperamylasemia, and then 3 of them developed grade B acute pancreatitis. So this is one of the important aspects of seeing the hypoperfusion of the pancreatic stump. And also for the quality of anastomosis, you can see that the HJ is clearly very green and is showing no leak from that, so we know that the integrity of the HJ is pretty good. The Chinese group have shown much use of the cholangiography to show the bile duct for duodenal sparing or duodenal preserving pancreatic head resection. And this becomes visible after 10 minutes, and you will see here as they follow the CBD in the duodenal preservation. So seeing the biliary tract, the common bile duct, they just follow these bile duct and complete the pancreatic head resection. So here you see the bile duct there clearly shown. So this is one of the uses as well for the cholangiography. And the more recent ones, the targeted probes are developing. They're looking at new fluorophores using panitumumab, bevacizumab, cetuximab, and SGM-101 as used for tumor detection, but these are all in the development stage. So these are all the challenges that I would like to share, because there's really no universally available and affordable NIR systems that would help us gain the experience and draw meaningful conclusions. And most of these studies are really small series, small center cohort studies focused on intraoperative visualization and short-term prognosis, which lack long-term patient survival data. And that is also because of the pancreatic factor, which shows limited blood supply to the pancreatic parenchyma in adenocarcinoma, in contrast to neuroendocrine tumor. Of course, that's a different biology all the way. And patients who nowadays, the current trend is using neoadjuvant treatment, and so the tumor necrosis also contributes another factor to the difficulty in enhancement and perfusion. And of course, the dense fibrous matrix of pancreatic tumors. So unlike hepatobiliary, unlike the liver and the cholangiography, where there's a whole lot of change in our practice. When I started in 2015, my dosage was so much, and until 2024, you can see the dosing has come down really much from, for example, for cholangiography, 2.5 milligrams being given 6 to 8 hours prior. Currently, we can only give 0.025, and we will see the same the bile ducts still show very brightly green and very nicely demonstrated. So we can actually give this already upon induction of the anesthesia. So there has been a lot of changes in terms of for dosaging and timing, for liver segmentation, for cholangiography, from 2015 until today, which is like 10 years in the making. And we know we have established this and practiced this in HP, in the hepatobiliary surgery, unlike in pancreatic surgery, where everything is still in the unknown. And we also look at some of we did some in-house studies and looked at the half-life, mainly because of the cost. So we are trying to share one vial of diagnostic green or one vial of ICG with many patients, but this needs the pharmacy to do it. And we tried to look at the fluorescence hour per hour until we have reached 120 hours. Even if it says 6 hours as a half-life, even at 120 hours, we are still seeing the fluorescence. So this has given us some idea on how we can probably partition the vial, because we are using less and less of this the contrast. And why are we doing this? Is because of the survey that we got from a small survey that we did during our workshop in Southeast Asia when I conducted this amongst different hospitals in 4 countries, whether they use this routinely for lab chole, because we advocate using this routinely. And you can see that the dose is different, administration is different, and barriers of adaptation really is the limited access to ICG, the cost, and also some says that the training, they needed a training. And even in liver surgery, the cost clearly shows as a barrier for adoption. So these are some of the things that we looked at and hopefully would help us together with the industry and work towards the possibility of providing better access and more economical ways. So in conclusion, most of the work for pancreatic cancer is still clearly at the developmental phase 2 of the ideal framework. And our goal, even if is to expand and optimize ICG applications in pancreatic surgery, mainly to identify all of these factors that I've enumerated, and hopefully that our goal would be to achieve R0 resection, better outcomes, mitigate complications better, and maximize survival so that we can achieve long-term studies, diffuses in multi-centers as well. I'd like to take this opportunity to invite you, and if you can extend this invitation to your friends and colleagues as well. We are holding the Asia Pacific ISFGS conference this July in Manila, and hopefully we will see you there too. Thank you very much.